Welcome to our second lecture regarding aortic valve. Particular attention we'll pay here is to aortic stenosis. Our learning outcomes here are to identify the structured aortic valve and what are the important landmarks around the valve. Then we'll go on to look at pathologies that are associated with aortic stenosis and what actually causes aortic stenosis. As part of aging, there's a typical process of sclerosis and fibrosis observed with the aortic valve. This continual process of scarring over a period of time leads the body to develop the formation of calcification at these points. Typically, it's a feature seen in the ages above 60 years. However, the calcification process is accelerated by genetic predisposition, diet, lifestyle, and smoking. Renal dysfunction and abnormal calcium metabolism may also accelerate the aortic valve calcification process. Calcification may form along the condylar tips, but is most prominent at the base of the leaflets, which leads to restriction of motion. Not only is the valve restricted in motion to opening, but potentially also to closing, and in many instances, varying severity of aortic regurgitation is also seen. So you can imagine if we got a big lump of concrete and we placed it in the door frame, you wouldn't be able to open or close the door appropriately. Calcification along the commissures may actually lead to fusion of the leaflets, and in some instances you could actually develop a bicuspid valve. Here we have a parasternal long axis view, and we can see our aortic valve. Here we have our right coronary and left coronary, and there's a heavy brightness to this area here, which indicates the calcification, and the valve itself is thickened. Not only that, we're actually in mid-systole, so we should actually see the leaflets having a parallel alignment with the aorta, which we don't see in this instance. When we rotate to a short axis view, again we can see the heavy calcification. In this particular one, it's mostly along the commissure lines and at the leaflet tips. M-mode still has its place in the current exam, and when M-mode is applied for aortic stenosis, we demonstrate what we call MAX, or reduced maximal aortic cusp separation. The leaflets will also appear thickened. Systolic flow obstruction from the left ventricular outflow tract is represented by a thickened leaflet trace different to a calcific tracing. This is due to a fluttering of the leaflet. Instead of the standard box-shaped motion, it is more triangular. Obstruction may be in the form of LV hypertrophy, dynamic function, the perpetuating muscles getting in the way of flow, systolic anterior motion of chordae, proximal septal bulge, or subaortic membrane. The features are seen in M-mode. As systole continues, the obstruction increases. The velocities increase, but the amount of flow actually decreases. And here we can see our examples with M-mode. So we've got our aortic root, and in the middle here we've got aortic valves. It's very difficult to distinguish the valves are opening, and the actual commissure, when they coapt, is very, very thickened. In our second example here, we've actually got LVOT obstruction, where we've got this fluttering motion to the typical box shape, and it tapers in a little bit more, rather than being a full box shape. On auscultation, it's a crescendo, decrescendo systolic ejection murmur. It is best heard at the right sternal edge and may radiate up to the carotids. It's a systolic ejection murmur as the ventricle must generate pressure to overcome the stenosis and aortic pressures before the valve opens, and thus we hear the sound. This murmur sound is typical of aortic stenosis, and the sound builds with intensity during systole. As myocardial cells fibers begin to relax, the LV pressure and the driving force decrease, and therefore the flow through the valve decreases, and thus the murmur intensity declines. A fourth heart sound may be heard. This is related to increased LV mass. Just like a bodybuilder lifts heavy weights, the heart working hard builds more muscle, which is not actually beneficial. The increased muscle mass takes longer to relax in the isovolemic relaxation time, and diastole, which leads to mild LV diastolic dysfunction. As aortic stenosis progresses, the diastolic dysfunction may also progress to moderate and then up to severe. Secondary findings may include LV systolic dysfunction, aortic root ascending aortodilatation, left atrial dilatation, pulmonary hypertension, pulmonary edema, right ventricular dilatation, right ventricular dysfunction, a raised jugular vena pressure, and peripheral edema. Patients may present with dizziness, syncope, chest pain, palpitations, shortness of breath and exertion, hypertension, orthopnea, and fatigue. And that's why it's very important with the GP, when they present for a consult, they actually take time to listen to the patient, because the presentation of symptoms can actually be relatively generic. Here we have an example of significant aortic dilatation post calcific aortic valve. And in this one here, we have significant aortic root dilatation and effacement at the ST junction. So normally it looks a little bit like an onion bulb. What happens is the root bulges out and narrows down and then comes up. But this is almost a straight line straight through. So with these lectures here, a sonographer can place the aortic valve in its orientation in relation to the rest of the heart and correctly identify the structures with a mirror image that is generated when we do transesophageal exams. A good sonographer can correctly identify clinical findings and patient symptoms on the referral using the knowledge to actually guide the exam. M-mode still has an application today, and it is important to be able to differentiate from stenotic and outflow obstruction patterns. It is also important to identify common associated findings associated with aortic stenosis and secondary complications with it. The echo study is much more than just evaluation of the stenotic valve itself.